Hi, everyone. My name is Shruti Mutalik, and I'm a consultation liaison and transplant psychiatrist at the Icahn School of Medicine at Mount Sinai in New York City. Thank you so much for watching our pre-recorded presentation. Our topic for today is altruism, privilege, and coercion, how culture, race, gender, and social networks impact living organ donation. And I have nothing to disclose. This is our DEI slide. And as you can imagine from the title, our submission does focus on equities, inequities, disparities in living donation, and it encompasses different aspects of identity, race, ethnicity, sex disparities. We also touch upon undocumented donors and special considerations therein, military and veteran donors, living donation through a DEI lens. My goals and objectives for this presentation are to, first of all, provide some background and context for some of the rest of the talks that my colleagues and friends will be doing as part of this general session. So I want to talk about the role of a living donor psychiatrist, provide a little bit of a broad overview of disparities, specifically racial in living donation, but also touching upon some other disparities. Of course, to make sure that we have a common vocabulary and a common terminology, I want to define key terms on the discourse on disparities and altruism and discuss the bias that's inherent, baked into altruism. So why now in terms of the timing? To understand the present, we have to understand the past. And going back just 4 years now in the past, think back to the summer of 2020, there was a global pandemic underway, gatherings were mostly virtual, and George Floyd had been murdered. And this is a picture of protests in New York City. To go into that a little bit, in the aftermath of George Floyd's murder, which was on May 25th, 2020 in Minneapolis in Minnesota, there was a national racial and social justice reckoning. There were protests. And of course, this reckoning encompassed many, many different domains of public life to include medicine, but far beyond the field of medicine itself. The ACLP, thinking close to home, made a commitment towards diversity, equity, and inclusion, and the DEI Presidential Task Force had its first meeting in September 2020, and one of their recommendations was to form a DEI subcommittee. Thinking about books, book clubs, reading, and education, there was a huge surge in book sales, about 6,800% by July 2020 of books that were on theme with understanding racism, understanding how to be an anti-racist, which was the title of a book by the scholar Ibrahim X. Kendi, White Fragility by Robin DiAngelo. Again, thinking from my own personal experience, we started on the consultation liaison service at Mount Sinai Hospital, weekly group reflections on race, racism, and anti-racism that are still ongoing. So as we can see, the year 2020 was a catalyst for thinking about disparities, equity, and inclusion. And medicine, as we know, has been rife with disparities and inequities in outcomes, in different aspects. And the COVID-19 pandemic, of course, highlighted some of these inequities. To talk a little bit about some of the terms that we'll be using in this context. So race. When we talk about race, we are generally referring to a social and political construct, even though often the term race is used to refer to a group of people who share some physical traits and often have some common ancestry, yet they are different things, and often social, cultural, and political forces such as redlining and its downstream effects, the race coefficient to GFR, some of these aspects, some of these specifiers can create disparities and account for a difference in outcomes more than any inherent biological characteristics. So that is one of the fundamentals of understanding race. Ethnicity is the term that we use to describe a group of people that share a common history and culture. And of course, this idea can be different in different contexts. For instance, in the United States, we describe Chinese as an ethnicity, whereas in China, there are about 56 different ethnic groups. And to speak a little bit more about race, these categories can evolve over time, which again illustrates to us how social, political, and cultural norms can define the inclusion of certain groups of people into a certain racial category. For instance, historically, Irish and Italian immigrants in the United States were not considered white, and that changed over the last 100 years. How does one define the race, or how is the race of somebody who is biracial identified, for instance? The term privilege, which is in our title, usually is used to describe an inherent advantage or benefit due to a certain aspect of identity that a group has. And one interesting concept in this regard is coming from the University of New Mexico, the sociology department. Nancy Lopez talks about street race, self-perceived race, and ascribed race, which illustrates some of the complexity and some of the difference in outcomes based on these different identifiers. Speaking of transplant, so one of the reasons why transplant psychiatrists are called to perform assessments, both of donors and recipients, stems from the fact that organs are a precious and limited resource. And I think that it is important to ground ourselves in this reality. Quick 101 about living donor psychiatrists and the role we perform. So all in donor programs and living donor programs, social workers perform psychosocial assessments, and in all centers, social workers perform psychosocial assessments. However, if there are yellow flags or red flags, any concerns about psychiatric instability or past psychiatric history, concerns about a substance use disorder or very complicated relationship with the recipient, if these kind of red flags or yellow flags are identified, then social work bumps up the assessment to psychiatry. At our center, there are certain assessments that are required by protocol for psychiatrists to perform. So all liver donors are seen by psychiatry, all non-directed donors are seen by psychiatry, and all swap donations are also seen by psychiatry. And of course, what we look for in these assessments is making sure that the donations are voluntary, of the donor's own accord, free of coercion. We want to understand the person's social support and context, the motivations for the donation, the relationship with the recipient, and of course, get a sense of whether they are above a certain threshold of psychiatric stability and don't have an active substance use disorder. So with that context, why are we talking now about inequities in donation? So the field of transplant, just like a lot of other fields within medicine, does have a lot of healthcare disparities, a lot of inequities, and going into them at length is sort of beyond the scope of our talk. But as an example, Black persons are 4 times as likely to develop kidney failure as white patients, and yet they have higher rates of kidney transplantation, even adjusting for social determinants of health. There was a study in 2021, and they have an average longer wait time, lower referral rates. So there is a lot of discourse about the inequities on the recipient side, and we thought that it would be important to sort of turn the lens on the other side of transplant, which is donation. And the complexity within that is that organ donation is a medically unnecessary procedure for the donor, even though it is life-changing, life-saving for the recipient. And you have to be healthy enough to donate an organ. So donation in that sense is a privilege, to be in good enough health to donate. And so, as you can imagine, a lot of social determinants of health, a lot of structural vulnerabilities might come to bear upon that. As an example of racial disparities, studies have shown that Black Americans have the highest prevalence of hypertension of any racial or ethnic group, and the rates of blood pressure control are significantly lower. Now, when it comes to kidney donation, one of the contraindications for donation is uncontrolled hypertension. So if you have hypertension that in some centers can be a contraindication in itself, but in some other centers, it has to be uncontrolled hypertension. And that would eliminate some candidates who come forward for donation. So that's one example of how you have to be in good enough health. And so structural vulnerabilities, social determinants that are responsible for poorer health outcomes in general would contribute to and impact the ability to donate and have a downstream impact on the rate of donation. And why do we care about donor diversity? So from the standpoint of recipients, a more diverse donor registry gives those on the transplant waitlist a better chance of finding a match. And so it does benefit recipients. Going a little bit into the data on disparities in living donation. So the UNOS has very extensive data, very extensive registry of donors right from 1988 until the present. And so as you can see, speaking of racial disparities in living donation, about 70% of all donors are white. As you can see, just the statistics and focusing on 2024. And Black donors are about 11.2% of all donors. So you can see that there is a significant disparity. And the ratio of directed to non-directed donors is about 14:1 in white donors since 1988. This is a significant thing. And looking at liver donation, you can see that, again, there is a huge disparity. 75.48% of donors are white donors, and Black donors are only about 3% of all donors. My colleague, Dr. Shenoy, will explore and discuss at length some of the sex disparities in donation. But as you can see, there is a significant disparity here as well. Females constituting about 65% of all donors, and males constituting about 34% of all donors. With regards to racial disparities, there is one thing that is, I think, important in the last decade or so, that is APOL1 testing. So APOL1 alleles, so if you carry two APOL1 alleles, they are considered high-risk alleles. So they significantly increase an individual's risk of developing kidney disease. And the risk of developing disease is considered 20%. So 1 out of 5 people who have APOL1 risk alleles are at risk of developing kidney disease, and about 13% of patients of African descent carry these gene variants. And so even though the general consensus is that it is helpful and informative for people to have testing, it is not generally considered an absolute contraindication. It is considered an informed consent kind of decision, shared decision making. It's sort of a balancing act between respecting someone's autonomy, but also doing no harm, equipping them with the knowledge of the risk of developing kidney disease. And one of the things that makes this even more complex is that even though there is a higher risk, as we talked about, 1 in 5, at the same time, the attributable risk is complicated and hard to determine and is lower than the absolute risk. Speaking about another population, undocumented donors. So here at Mount Sinai, undocumented donors do donate organs. And looking at this article, the challenges of being undocumented and dealing with kidney failure, I think one thing that comes to mind is that being part of, maybe a marginalized population, a population that may have difficulty with access to care, there can be challenges with having a chronic healthcare condition like kidney failure And within the social network of such undocumented recipients, there may be people who want to donate a kidney to them. So I think that often a reaction that people, or a response that people might have to hearing about undocumented donors is that, is it ethical for somebody who may have difficulty with access to care to donate an organ? And I think that with respect to that, there are a few things to consider. One is that undocumented donors are not a monolith. So there are undocumented donors that have a PCP, have access to care, live in a sanctuary state or a state like New York, where there are options for healthcare for undocumented immigrants. But there also may be undocumented immigrants that don't have access to care, that don't have a primary care provider, don't have social support. So I think that it's really important to be careful about wanting to protect, but at the same time wanting to respect autonomy, and on a case-by-case basis, recognizing, is the power dynamic, is exploitation or coercion coming into play, and do we need to sort of advocate for the patient by not clearing them for donation, versus is it important to give them a sense of autonomy, and are we actually helping them if they want to donate to a spouse or a child, etc. All right. Well, speaking about disparities, it is very important to acknowledge the disparity that's inherent within altruism. So a quick definition: generally, when we talk about altruism, we talk about the regard for the devotion to the welfare of others, or other-oriented behavior, often at cost to oneself. And etymologically, it comes from the French autrui, which is referring to other people. One quick note here is that we generally use the term altruism to talk about selfless behavior and helping other people, but in moral philosophy, it actually has a slightly different meaning. It is an ethical doctrine that actually regards or places value on the actions of an individual based on the impact of those actions on other individuals. So it has a slightly different meaning. And speaking of altruism and the desire to help others, that can often be born out of imagining or placing yourself in the shoes of others. But as Paul Bloom, the philosopher, has written about extensively in his book, Against Empathy, he talks about how empathy can be a poor guide for moral decision-making. It can motivate people to be kind on the one hand, but at the same time, it's sort of like a spotlight which directs attention to one particular situation that pulls at your heartstrings, and that may not be the most effective way to sort of direct your resources. So as an example, one example where empathy can backfire is, let's say, you're part of a jury and there is someone that is able to sort of share their story in a way that pulls at your heartstrings. And there's somebody else who is innocent, who is not able to do that. The biases within empathy might make you respond more strongly to one person's story than others. And so in a way, you're not making the most optimal moral decision, even though you're being kind. There are, speaking of different groups of people and different stories that might target your heartstrings, in terms of organ donation, there is an organization called DOVE, Donor Outreach for Veterans, which is an example of an organization, and this is their website, that helps connect people, potential living donors, to veterans, military veterans that are in need of a kidney transplant. So as you can imagine, there are people whose heartstrings might be tugged at by the idea of helping a veteran who is in need of an organ. This actually was created back in 2020 in response to the fact that the VA wasn't doing a large number of kidney transplants. It was doing only about 160 kidney transplants a year. And so this started in response to that. Another organization that my colleague, Dr. Barnhill, will be focusing on at length will be renewal, which again connects Orthodox Jewish donors to Orthodox Jewish recipients. So this is an example of different populations and how there are ways in which organ donation is solicited with different groups of people that may draw upon the altruistic drives and impulses of different groups of people, but there are inequities and disparities within this. And this is a slide to show that there's a very high percentage of altruistic kidney transplants that are attributed to renewal in the region of New York and New Jersey. My colleague, Dr. Barnhill, will speak much more at length about effective altruism, but effective altruism is basically proposed as sort of a little bit of an antidote to some of those concerns that were expressed about the biases that are baked into empathy, how altruism and the altruistic drive are not necessarily equitable or rational, but there may be a lot of countertransference and bias, etc., involved. And the idea behind effective altruism is sort of a more rational, more sort of calculated allocation of resources. And this is Peter Singer, whom, again, Dr. Barnhill will be talking more about. He's a controversial philosopher who has talked about effective altruism. And effective altruism has parallels with transplant in terms of thinking more practically and pragmatically about ways in which to allocate limited resources and help and aid people fairly. But there is much more to follow in our session. So some of my conclusions are that disparities in donation are complex and multifactorial. They occur due to a multitude of different factors. Some of them are individual biases in the altruistic drive, and some of them are more systemic. They are inequities in race, in sex, in immigration status, and these are, of course, due to social, cultural, and political forces. And altruism and the altruistic drive can be complex, can be biased as well. And as living donor psychiatrists, understanding the context of these disparities at the micro level can certainly enhance our biopsychosocial formulation of patients. It can help us understand the patient in front of us better and watch out for certain things. And on the other hand, at the systems level, it can help inform and direct our efforts at advocacy. Thank you so much for listening. And now I would like to hand over the talk to my esteemed colleague, Dr. Debbie Kahn.
Thank you, everyone who is here watching our presentation. And thank you, Dr. Mutalik, for your wonderful orientation to this topic and for organizing us all to work on this project together. So I am going to be talking about social networks and living donation, strategies for reducing inequities. I have no disclosures. The learning objectives for today are to review the benefits of living donation and different types of living kidney transplants, to discuss the most common types of relationships between donors and recipients, to explore ethnic and racial disparities in living donation, and to understand the intricacies of leveraging social media and social networks to increase donation. I wanted to quickly review why living donation is important. Recipients who have living donors spend less time on dialysis, and in some circumstances, spend no time on dialysis before getting their transplant. Living donor grafts function more quickly and more completely than deceased donor kidney transplants. Then finally, the longer graft survival has been noted for a number of different years in living donor kidney transplants with an average of 19 years versus 11.7 years in deceased donor kidney transplants. There are different types of living donor transplants. The most common type is a directed donation. So this is a circumstance where someone wants to donate a kidney on behalf of an identified person. This can be a family member, a friend, a coworker, or someone they have noticed on the internet who they'd like to donate to. They may or may not actually be a match for this person. If they would like to donate to them, but they are not a match, they have a few different options. One is to do paired donation. This would be typically a simple swap where candidate A donates to candidate B and vice versa. Now, sometimes a simple swap is not available, in which case people can consider registering with the National Kidney Registry and even donating into something called the voucher program. So the voucher program allows donors to donate as soon as they are ready to donate, even if their recipient is not completely ready to go through the surgery. It also helps to get better matches in the case that a donor is not a perfect match with the recipient. Donors can also choose to give 5 vouchers to family members or other contacts if they do not have a recipient imminently in need of a kidney. In this case, only one of those vouchers can actually be redeemed for a kidney transplant. Finally, the least common type of donation, but also very important, is a non-directed donation. We also call this an altruistic donation, where someone donates a kidney to anyone who is on the list. The donor and the recipient may or may not choose to meet. Both have to be in agreement if they are going to meet. So why was I interested in this topic? I have worked with the kidney transplant group at UC Davis for about 15 years now, and I have seen all sorts of interesting trends in kidney donors, and I was curious to learn a little bit more. One situation that stood out was that multiple donors stepped forward to donate to one potential recipient who had advertised on the back of big rigs. So many people had been stuck behind a truck on the freeway, sometimes for hours. And it just occurred to them that the sign that was posted about a kidney recipient spoke to them, and this was meant to be. So we probably evaluated 20 potential donors for this one recipient. I also have seen numerous donors come forward wanting to donate to someone who was a friend of a friend on Facebook. So this was someone they had no relationship with, but something about the posting spoke to them and they came forward. Finally, one of the more successful campaigns I saw was a person who wore a sandwich board on a street corner advertising their friend's need for a kidney donor, and they were also successful. So this is in contrast to many recipients who don't have any donor applicants. They feel uncomfortable asking for donors. They don't have social media, or they may have lost many of their different social connections since living with chronic disease. So I find myself talking to recipients about campaigns I have seen. I coach them on finding an advocate, setting up social media, and just found myself wondering overall if a standardized approach to helping recipients would be helpful. I reached out to our donor team, which included an RN and social worker, and asked them how they coach people on finding a donor. So they said a few things to me. They said, you need to talk to Rosie about our donor applicant data, and you really need to ask the recipient team, because they're the ones who are coaching recipients on getting a donor. And they said, check out our website. I think we have a lot of resources there. And by the way, we do have a lot of donor applicants. We have about 2,000 a year. Some more about my thinking was, with a social media campaign, it would allow recipients to reach a wider audience with their story, using visuals to generate empathy. It would also be a platform for educating people about living donation. It also allows recipients to reach out in a non-confrontational manner to allow potential donors to read at their leisure and step forward if they felt like it. So I did contact Rosie, and Rosie has all of our data at UC Davis, and she was able to do a couple of searches for me on a program called MedSleuth. So this is a standardized applicant form called Breeze. It's available in Spanish and English, and it's online. And so we have all of the data for applicants that have come through in 2023. So almost 2,000 completed the Breeze application. And of those, about 1,000 screened in, which means about 900 people were screened out from the initial Breeze application. There were 675 unique recipients associated with the 1,000 screened in donor applicants, meaning many of the recipients had more than one potential donor. I have a little bit of data on who was screened out, and the main reasons people were screened out were BMI over 35, tobacco use, and hypertension. We have no data currently available about relationship to recipient or the ethnicity or race of the donors. As far as the relationship of the donors to the recipient, it was about 50-50, family and not family. I do want to note that the way Breeze and MedSleuth categorize relationships is a little bit different than how UNOS does it. So Breeze looks at family relationship, which includes biological and non-biological family members, versus UNOS, which categorizes biological versus non-biological. So what can happen with UNOS is a spouse or partner is categorized as non-biological, whereas in Breeze, those donors are categorized as a family relationship. So what are the other relationships? Members of the same community, about a quarter, met through social media, 18%, acquaintance 17%, coworker 12%, and undefined 28%. When we looked at racial self-identification in the donor applicants that passed the phase 1 screening, here is the breakdown that we found. Now, I will note that there is an idiosyncrasy of the Breeze data, which is different from the UNOS data. Breeze categorizes race separately from ethnicity. So race has a number of different possible categories, whereas ethnicity only has 2, Hispanic or non-Hispanic. So we can see that the majority of applicants that screened in were white at 61%. But there's no Hispanic Latino on this because this is considered separately under ethnicity. So at our center, we did have 27% Hispanic Latino and 73% not Hispanic Latino. So how many of these applicants actually completed living kidney donation? I have to say that this is a difficult transition from one data set to another data set. So I'm at this point jumping from our Breeze applicant data to UNOS completed kidney donor surgeries. Roughly, if we look at all of 2023's donor applicants, and then translate that to June of 2023 to May of 2024 completed donations, I'm hoping that approximately lines up with the people who applied during the 2023 year. So of that 1,000 donors, we had 64 living kidney donations. So again, translating data from one system to another is not smooth. I made a lot of assumptions. Forgive me. What we did find in the UNOS system of biologically related donors, there were 29, and non-bio donors there were 35. Now, if we move the non-bio donors who were spouse, close friend, or partner over to bio donors, then we have a slight preponderance of family donating as compared to non-family. So what that means is we have more family that completes the donor process with the surgery. They're overrepresented as compared to those that were in the applicant pool. Some more about our living donors who completed. White donors accounted for 53% of the completed donation. Hispanic Latino accounted for 33%, Asian 8%, Black donors were 2%, multiracial 3%. So again, this is a problem with jumping from one system to another. Hispanic Latino were considered in a lumped together ethnicity/race category in UNOS versus two separate categories in BREEZE. So I wanted to see if our population of completed donor surgeries was at all similar to California as a whole. And it turns out we have a higher rate of white donors than the rest of California, and a lower rate of Asian and Black donors. The rates of Latino donation are about the same at our center as around California. What about the country as a whole? When you look at the country as a whole, in 2023, living donors were almost 70% white. Overall in the country, Hispanic donors accounted for 17.5%, Asian 4.8%, Black 7%. There are also donors within the categories of multiracial, Asian Pacific Islander, and Native American Alaskan. Another question I asked is there a difference in type of relationship between donors and recipients according to race/ethnicity? And surprisingly, there was a pretty big difference. So white living donors had almost 70% donation to non-biological recipients versus Hispanic and Black living donors were about 50-50 with donating to non-biological versus biologically related recipients. So what does this all mean? So living kidney donors are overwhelmingly directed. So they direct their kidney donation to a relative, friend, coworker, community member, or someone with a more distant relationship. Looking at UC Davis, around half of donor-recipient pairs are not biologically related. Nationally, there are differences in donor-recipient relationships between ethnic and racial groups, with increased rates of non-biological donations made by white donors. We need more information about why these differences exist in order to increase equity in donation, and data on living donor applicants who are screened out would help with this assessment. So back to the original question, what about using social media to improve our rates of living donation? There is data. So there was a study where recipients were coached on using a Facebook app in 2016, and the success rate in having a donor apply to donate to a recipient, they were 6.6 times more likely to have a donor applicant than those who were not coached on using this app. They did not report on how many actually completed surgery, but this was an impressive increase in the number of applicants. So one plus 2 equals 3. Why don't we do this? Well, it turns out that the first equation is not such a good descriptor. The second equation on the right is more like what we have to consider when moving towards a emphasis on social media as a way of recruiting donors. What are some of the pitfalls of these social media campaigns? Initially, recipients have to post information about themselves, which may cause them to violate their own HIPAA rights. They risk publishing personal data online, and they lose control of this data. They can have their medical identity taken. There can be fraud. Insurance companies can view their data. Employers can view their data. We also saw a rise in uneducated applicants who at times seem to overwhelm our donor group with so many evaluations, and they didn't really have enough information about what they were getting into. There's a lot of inequity in access to social media, and this can exacerbate disparities rather than improving access. Social media can spread disinformation. And then we also have ethical questions about encouraging non-directed donation in the case of someone who has multiple donor applicants who don't necessarily know them, but they have a compelling campaign. In this situation, do we refer the extra donors into the exchange? Do we encourage non-directed donation? Do we tell the recipient about all these donors coming forth to donate to them? And finally, donors and recipients can have unrealistic expectations about what will happen, about the relationship in the future. And the transplant centers are the ones who have the burden of having to correct these unrealistic expectations. While what we would like to have is the tree on the left, which is balanced and symmetrical, and all of the branches are equitably distributed. What we end up with, if social media is used in its current state, is an unequally growing tree, and disparities are increased rather than decreased. UNOS has some guidance on the use of social media. They recommend using a toolkit with vetted materials that are available online, in print, and in multiple languages. They recommend presenting the toolkit and other resources about living donation at multiple points in the recipient's journey. They recommend involving family, friends, and a donor advocate in launching a social media campaign, and then having a dedicated team to coach, review, and monitor social media outreach efforts. There are also other programs that have sought to increase equity in donation. A work group formed by the Organ Procurement and Transplant Network and United Network for Organ Sharing Living Donor Committee reviewed interventions to increase living donation. The different articles reviewed in this paper looked at different outcomes, including donor inquiries, donor evaluations, completed living donor kidney transplants, and then recipients' comfort about speaking about donation, increase in knowledge, and percent change in non-blood related living donors. Amongst all of the studies they looked at, the most promising interventions included house calls, which was a combination of clinic-based education and home-based education, where members of the donor team, as well as experienced donors and recipients, would visit patients and their social networks in their homes and provide education. This resulted in significant increase in transplants. Seminars on Saturdays had some similarities in that people had education with their social networks outside of normal clinic. The percentage of non-blood related donors among total living donors increased significantly in this study. And then finally, having a live donor champion. So this would be a recipient enlists a support of a friend or family member who can help do outreach on their behalf. The conclusions and recommendations I have after looking into our statistics on living donors are the following. Living donors are likely to have a social or familial relationship to their recipients. Nationally, white donors are more likely to donate to non-biologically related recipients, while Hispanic and Black donors are more likely to donate to a biological relative. A UNOS MedSleuth collaboration could increase our knowledge about living donor applicants and barriers to completed living donation. Leveraging social media networks to increase living donors is effective, but has a number of pitfalls and may increase inequities in living donors. And overall, the most effective and equitable living donor recruitment efforts include core educational material for transplant donor candidates, a multidisciplinary team to educate donors and recipients, including actual donors and recipients for more information. This education takes place at multiple time points with coaching that is ethnically and culturally sensitive and effective. And finally, that transplant centers educate recipients about the safe use of technology and also help them to launch these campaigns. Thank you. I will now hand off to Dr. Akhil Shenoy.
All right. Thanks, Debbie, and thanks, Shruti. This was really nice for Shruti to Dr. Mutalik to invite us all to kind of discuss different aspects of disparity in organ donation, living organ donation. So I'm going to talk about living donor gender gaps, and my subtitle here is Too Few Good Men. So nothing to disclose. And what I want to say is that, we'll start with this case, a very inspiring case that I saw last year, 56-year-old man who's a general manager of a professional team, kind of a big national team with, he had a liver cancer and it was recurring and he had necrosis, but he didn't have any symptoms, low MELD, so he wasn't going to be high on the list. Unmarried, no kids, so we kind of reviewed living donor options and they seemed to be screened out, but he was doing okay. Then he starts to develop some symptoms, and then one of his close friends, who's also the assistant coach, creates a social media campaign to help enlist donors. And over 3 months, there are 97 inquiries for this man, and 21 come through with paperwork, and you see 17 males and 4 females, and then 11 completed labs, 8 males and 3 females, and then 6 went into full evaluation, which got the full psychosocial evaluation, psychiatry and social work, saw 6 patients or 6 potential donors, and there were 5 males and 1 female. You can only imagine what happened. So this kind of inspired me to figure out what is there, are there gender gaps, and why are there gender gaps in living donation? So the UNOS database is a very good resource. You've seen this before. I think Debbie highlighted this, is that, and Shruti, that the idea that in the United States, there is a gender gap with kidney donation. It's about 64%. Look at my region, Region 9, which includes New York, it's about 61%. And then I look at the data for our center at Columbia, it's about 56%. And the same similar, inequity happens with living donor liver transplant. Not as striking, but it's there. And so that's why this sort of talk came about. And so today I want to talk about 3 things. One is I want us to hypothesize together the reasons for these gender gaps among organ donors, kidney and liver. I want to try to explain the ways to reach gender equity among living donors. And then I want us to sort of come up with some concrete ways that psychiatrists can actually help improve living donation in this spirit of, in these ethical principles. So here's my first question for all of us. Is the problem that there's too many women living donors or too few men? All right, so let's go to the data. So living donor by sex, according to UNOS, and here Salas has reviewed this and done a nice table here about over the years, the disparity is just growing. So there's more and more women donating than men over time. And you see that with that blue line. Okay. So what does that mean? So that is the United States data. And I'm going to sort of pull back a little bit because, you know, at this point, and I have this data from 2019, and it's even, it's even grown since then, is that more and more other countries are doing increasingly number of transplants, and both deceased donor transplants and living donor transplants. And some countries do a mix of them. Some countries do much more living donors, like India and Turkey. And some countries do much more deceased donor transplants, like Spain and France. So there's an interesting sort of background, and we'll get back to this slide because I think it's important to get context. Because I wanted to look at, this story globally. What's going on around the world in regard to this gender gap? And here's a nice study that surveyed 64 countries around the world. It's so small, you can't even see it. But trust me that the average, the mean across all these countries was 61% female donors. That was for kidney. And then for liver, it was about 51% female donors. And there's a lot of variation there. And, in that story, there is also some countries, and I'm not going to include the countries way at the bottom who have very few donors, like 1 or 2, 3 donors. We shouldn't count those as much. But the countries that do a lot of transplant, like India, has a lot more female donors, some like 70%, some centers 80%, 85% female living donors. And I think that's a strange gender gap to sort of, kind of review. Now, there are countries that have are about even. So we get to that too, and we'll think about that. And then there's one very interesting and important exception to this. It's not included on this table if you can't even see the names of the countries here, but if you look closely, the name of this country is not there. It's Iran. And Iran did a nice review of one of their centers, to 1,500 live kidney donors, which is one of the biggest centers there. And they looked at their gender gap and they put it under scrutiny. And then they saw that in their situation, it was mostly men. And in fact, because most of their donation is living donation, and at that living unrelated donors, it's mostly men. And in that group of living unrelated donors, it's 91% male. So that's interesting. And by the way, I'll go back and forth with so in our database, sex has been as is the birth sex is included, but often we talk about gender as Dr. Mutalik said, is that we describe gender as a descriptor, but this is mostly I think the way they're describing here in Iran is mostly males are donating. So here you have to only look at the title of the study, and then closely is that they started a compensated living unrelated donor program back in 1988. So if you are a living unrelated donor, you receive a donor award from the government. You also get a gift from the recipient, which is a compensation package, and it's the only country in the world that allows, as a compensation for to pay for the organ, not just to offset cost. So you look here to see if, looking at related donation in Iran, it's about even, so male to female. So, I wanted to see the research, and sort of there was a nice scoping review done recently about why there is a gender gap, and they break it down into 3 different areas. One is socioeconomic factors, which kind of is maybe related to the Iran story and very likely related across a lot of different countries, because of the 14 studies that looked at this, they included family income was a huge factor when people said questions about who was going to donate in the family. So some of the themes were that the male was the breadwinner and couldn't donate. The female was the woman of the family was not able to was able to donate and wanted to donate and was not working. Other issues were the insurance. Men were less insured, which sort of was an explanation of why some men don't donate. And then certainly we talk about finances, like in a country like Iran. So those are some of the factors, but I think underlying this is this question about, is this a sort of male privilege? And I think that gets back to the theme of this talk. Is there sort of underlying, apart from the expressed description of why these factors are influencing the gender gap, is that what it is? Is that what's, so I don't know, but that's something that we should think about. Now, if they did a nice study on living donor liver transplants pediatric, they looked at different countries across the world, and they saw that this gender gap is wider in the lower income countries. So that kind of speaks to sort of that idea of that sort of maybe a patriarchal system. Maybe there's sort of the male household is like run by the male, and there's a financial incentives for that person not to do the donation. It's possible. So what's not possible is that biological reasons are the reason for this disparity. So there's one potential reason, and that's related to spouses, especially a woman donating to the father of her children, so where she's been sensitized to blood products that will make it challenging for the recipient to accept the organ. So that's not a very common situation. The more common situation is that women are ruled out for variety of issues, like in kidney, for maybe kidney disease, or the risk of I think women maybe should be counseled about the risk, if they're going to have another child, of preeclampsia, the higher rates of preeclampsia in patients who have been kidney donors. So, I mean, these are reasons to counsel people out, to counsel women out of being organ donors, but these don't explain why more males are organ donors. So what may be another feature which the scoping review did was looking at individual factors, emotional factors, cognitive like ideas about donation. So women tended to be more determined about donation, had identified themselves earlier as the donor. They were more optimistic and positive about being the donor. And they were more likely to talk about it with their family. They were not interested in compensation. They were not interested in being the hero. Those are themes that came up. But what is that? Why is that? And I think that in our discussion with our colleagues here, we have to sort of wonder, is that latent sexism? Is there sort of other, socializations that are happening that lend itself to this? And then why are there fewer men? I mean, the men with fear of complication, I asked one of my friends who's an analyst, he's like, is this castration anxiety? Because our trainees were wondering if this is castration anxiety. So then, well, it's an interesting question, but I think the analyst said, no, these are sociologic issues. These are not, you can't do psychodynamics on this. Anyway, the concerns about the scar were a bit mixed in this review, but I think a lot of food for thought. So more data, which is that the gender gap continues to exist across different relationships. So it doesn't matter if it's a blood relation or a non-blood relation or non-biological relation. Altruistic or anonymous non-directed donors still skew towards women. So in all categories. So that's interesting. So why is that? So, we get to this sort of, everyone wants to talk about these sort of stereotypes, or like, so I had to add this slide, how men deal with illness and how women deal with illness. And so that's an important question, interesting question. I mean, I think there was a study back in 2006 where they looked at this gender gap and with living donor kidney transplant, and I think there was this sort of concept where they looked across the whole group and there was a gender gap. And but then they looked at because it cut across a couple decades, they saw like the open nephrectomy versus the laparoscopic approach. And they found that when they instituted the laparoscopic approach, the gender gap kind of disappeared, which is interesting. Which sort of, there was an editorial about this. So the editorial was, are men really wimps? So that was the question. And, it comes up with a lot of ideas about, is it because they have to be out of work for a long time? Or is it because they're worried about feeling sick? Being in pain came up. So is someone's, sort of in this editorial, I think one of the authors sort of, just wondered if it was because women had gone through pregnancy and they've experienced pain, so are more willing to be a donor and go through pain again. These are all questions. I mean, I think, if you look at the long studies by the A2L group of living donors, living liver donors over time, men tend to be in that higher group of like having low psychological benefits and then potentially some physical problems, but also having high socioeconomic costs. So they tend to be in that regretful sort of group. That's interesting. Anyway, so this scoping review, I think looks at these two features, which is what is encouraging women to come forward as donors, what is discouraging men to come forward. And so there's a nice slide of the summaries of all that we just discussed. So to my theory, my own personal, from working with these patients, is that there's a little bit of a bystander effect. And what does that mean? Well, there was one, it's a little old now, but they looked at, surveys of people with siblings. And, they said, if you have one sibling, well, it's a 51% chance of that sibling donating to you. But if you have 10 or 11 siblings, it's a 20% chance that any one of those will donate to you. So that's an interesting phenomena. It's, otherwise it's called the kind of diffusion of responsibility. The responsibility is, kind of falls away. And what I experience is that oftentimes the women liver donors come forward and before anyone else. And I think that's, I wonder, and I ask my patients this, is that did anyone else volunteer? And I'm always asking, is there another person that's going to come forward if you don't come forward? And I think that's this question that people have to ask. I mean, as psychiatrists, we have to ask our potential donors, who else is in line? So, no, so before I get into those questions a little bit, I just want to give you a little bit more background. This is just a second to kind of look at the deceased donor gender gap, because this is a very interesting thing, is that in America, that even though more women donate or living donors, that more men are deceased donors. And I think that's an interesting phenomenon in itself, and why that's happening is unclear. And there's not a lot of data on this, but I mean, maybe related to, male donors being more viable, possibly. So, but this is across the world. You know, the same rate is 60-40. And if I could just sort of summarize here, is that you're looking across the entire world at deceased donors, and with some exceptions, few exceptions, it's women are more likely to be living donors, 60-40. And men tend to be, across the world, men tend to be more deceased donors. So I think with that, I think the question is, are these gender gaps problematic, specifically for transplant? And so you can look at outcomes, and you can look at heart transplant outcomes for deceased donors. And yes, they are problematic because the female to male donation ends up with the worst outcomes. So that is a problem for heart transplant. It's also a problem for kidney transplant. So the female to male donation, the recipient does the worse. If you know, but with liver, it doesn't. Liver is not so much. But nonetheless, this is an important outcome to think about and consider, because we're here to not only increase and improve transplant at the center, but improve people's lives and their quality of life, but also their survival. Sure. So, but that, I guess we get back to this question, is like, beyond these usual transplant outcomes, should we be just striving for gender equity in transplant? We work with these patients, we see recipients, we know that kidney recipients, there's only, it's 6 for, even though the burden might be equal, or even there's more organ burden or, you know, kidney damage in women, men are more likely to be to come forward for evaluation and be listed. Yet they're women are more likely to be the donor, so with the living donor. So shouldn't we be striving for something more equal? So that's what I wanted to talk about in the end here, is that how can we achieve gender equity? And I think there's 2 approaches here. One is to evaluate as psychiatrists and as part of the team. I think trying to make sure that we're evaluating for coercion and to consider the social pressures on women candidates. And I think on the other end, I think is trying to figure out how to increase living donation among men. So that's the 2 things here. And we go back to this case, which is a fun case, because these 6 people went into eval, and I'll tell you, a 56-year-old man, or he was, well, so reveal it. He's a highly motivated, he's ruled out for steatosis. 58-year-old, highly motivated, ruled out for size issues. 53-year-old, super ambivalent, didn't come back, didn't finish the eval, ruled out. 40-year-old, highly motivated. She's, history of anxiety, on an SSRI, and was the donor. 38-year-old, ambivalent, spouse was super concerned, conflicted, ruled out. So the spouse said, no, you shouldn't do this. 40-year-old was intoxicated at the time of the video visit, and he was struggling to keep up, and he was ruled out right there. So, if the question is, if it's too few men, is it because they're not coming forward or getting ruled out? And I guess that was my question. So I looked at the data at Columbia for the last 3 years, and for kidney, the number of evals for women donors was way more, like on par with what we talked about, but the clearance rate was the same. So they weren't getting ruled, like men weren't getting ruled out. That was not the issue. With liver, it was a little bit more mixed. I mean, certainly more women came forward, but more men were ruled out. So that's interesting. Now, if you go back to this case, in this situation, yeah, all these men were ruled out, and the woman was the one that donated. But I think in general, if you look at this, because there's other studies that have been, there's a recent study looking at this, the reason for the gender gap, in at least in these parts, I can't speak to the rest of the world, but is that probably more self-referral as opposed to men getting ruled out. But I think that's something to think about. I'm not sure if that's everywhere, so we have to study that. So what do I do? I mean, I think, as I know Dr. Mutalik had mentioned this, is that we, as a transplant psychiatrist, we're constantly evaluating patients for donation, and we live somewhere in the middle here after these patients have already declared themselves as being super motivated and wishing to be the donor. So if you look over here on the, all the way on the left, it may have been weeks, if not months, that the patients become committed to this idea of being a donor. They've had their moment where they decided, and then they've already sort of assumed responsibility in this whole process. And so as they navigate through this system, they see us, they're sort of, again, looking at the risks of being a donor, trying to evaluate those risks, put them into context. And we're trying to assess them for their sense of the risks. We're also trying to, with the social worker, trying to assess their support structure and who's going to be there for them, and to make sure that they know that we've identified a living donor advocate that can help them make decisions. And they're in this sort of very tight space of getting evaluated. And what I like to do with patients is certainly talk about the benefits of donation, because we all talk about altruism, but actually there are benefits of being an organ donor, and we have to express them out loud to sort of review them. And you're welcome to go to this very nice, it was focus groups looking at patients that had donated and describing what they found as benefits to being organ donors. And they're like organized by health and well-being benefits, time and financial benefits, interpersonal benefits, and there's also all these non-tangible benefits like feeling of connectedness, empowerment, satisfaction. And all of that, I think, is where the patient wants to be. But en route to that, we go through, this is nice, Hansen described, again, it was focus groups, or prior organ donors who are trying to describe their process of going through it, managing risks, and sort of things in the dark, or things that kind of dissuaded them from doing it, and things in the light, or things that sort of encourage them to go forward. Part of our job is to analyze all of this and to evaluate them in real time to see where their head is about being an organ donor. Now, what can we do very concretely? And what I tell my trainees is listen for the social pressures, especially here, the social pressures related to gender. Listen for the sense of responsibility that this patient's taken on, this donor's taken on. Try to understand their financial pressures, which I think is important here, and specifically what we talked about today, and the benefits of donation for that patient. Now, Dr. Khan, likes to ask, I'm going to steal her question from now on. She asks, why you? And is it always you? Which I love. Is it always you that's the one that does everything for everyone else? I ask, are you the only one? Do you know if other donors are donating? Do you feel like you're the only one in the world that can do this? And I ask, what would you do if you weren't the donor? What would you do? How would you manage your motivations to help this person if you couldn't be the donor? So I think, as per Dr. Mutalik's comment, if there's clear coercion, we have to rule out patients. But I also want to make sure that we're advocating for patients who are clear and want to be donors, and I don't think we should be looking for strange reasons underneath. Maybe if they're wishing to be a donor, we should, and they have their head straight about it, I think we should probably accept them. But that's a sort of segment. But so what can we do at other levels? So at the center level, what we do, we have a living donor champion here. So I think part of her role is to look at social networks. And I think given that I've just done this review, I think I will encourage her to sort of help them find more male living donors. There was this very nice study about Rodrigue up at Beth Israel Deaconess about going into the homes and talking to families directly about how to, manage who's going to be the organ donor. That's a nice intervention. I think I was wondering about creating more donor education that is male-centric. That's an idea. I think this is already being done, but this is happening. So to increase male to female spousal donation through desensitization, that is an interesting idea. And then we're already doing this in nephrectomy, but we're doing this at New York Presbyterian is doing laparoscopic hepatectomy, which I think is potentially a boon to sort of also reducing this gender disparity. And at the population level, I think we have to wonder, and these are well outside the scope of what we can change as individuals, but we have to wonder about protecting against lost wages and universal insurance. We have to think about the socio-cultural barriers, right? So I think there should be potentially a greater donor identity among men. And maybe we have to build a sense of donation responsibility among men. But these are, these are sort of bigger fish to fry. So, but thank you for your time, and welcome to, I guess you can hit me up at Transplant Psych if you have questions. That's Twitter.
Hi, I'm John Barnhill, and I wanted to talk about a couple of ways to intrigue people into non-directed living kidney donations, which, as we've heard today, and which probably most of you already know, is an unusual way to donate a kidney. Most people either donate after they've died, or they are donating directly to somebody they do know. But I want to talk about this less common way to do it. Just wanted to disclose that I get paid for writing chapters for the Merck Manual. We're going to talk about ways that people are encouraged to donate when they don't know somebody with end-stage renal failure. And then particularly, I want to talk about two of the most common pathways, which are renewal and effective altruism. You may know about both of those, you may know about neither, but I just want to introduce you and then also provide a few resources and questions in case you would like to explore them further. I won't go into great detail about some of these things, but we'll provide references in case you would like to do a little reading or listen to a podcast or there are TED Talks. There's a lot of stuff you can get into. I wanted to mention, it's already been mentioned, but I want to mention again that some groups tend to be marginalized and less likely to be eligible to receive or donate a kidney. And it's partly because people like me are looking for capacity, are looking for their ability to remain adherent, their psychosocial stability. Are they going to be able to maintain insurance for decades when they might lose it? And so people with cognitive impairments, or who are who don't have a home, or who are don't have a good social network, or who have a substance use disorder. There are various ways that people might be ineligible to donate or to receive a kidney, and so they get sort of systematically excluded, which makes it more difficult to find donors. Lots of groups are looking for living donors, and both for people they don't know as well as relatives and friends. They're listed here. I'm not going to talk about them. Then there are smaller focus groups that are often spurred by an individual, and they make a personal appeal. That might be through social media, billboards, talking to friends and family. There are special interest subgroups like veterans or firefighters or police. There was a episode in which the Colorado Children's Hospital put out an alert saying they had 10 kids who needed transplant, and they got, I think it was 100 volunteers, which was great. But I wanted to talk about effective altruism and renewal, and talk about how they work to get people interested. And the concept of altruism, we've talked about it today, but it's an interesting one. Is it really altruistic, or is it something that they get out of it? What do they get out of it? And how much do we as kidney psychiatrists look at people's motivation? Is it okay to say that they want to do it to help the world, or that they want to do it because it's God's will? Is that a good enough motivation? Or do we say, sounds good, it fits them, it may not fit my view or many people's view, but it's good enough? Primum non nocere is kind of underlies medicine. Do no harm. Is it okay to do surgery on a healthy person? Maybe it's okay for a relative, maybe for a friend. Is it okay to do surgery on a healthy person who wants to give to a stranger? But I think it's important to recognize the benefits don't have to be physiologic. They can be psychological or interpersonal. That people often, in my experience, feel really good after they have donated. And even if they have some kind of side effect afterwards or some kind of complication, they feel good about the donation. By and large, I haven't really run across people who regretted it. Some of this may have to do with biblical things that even if they're not religious as adults, they learned a lot of this stuff growing up, and that's through various traditions. The Christian tradition, whoever has two coats is to share with him who has none. In both the Talmud and the Quran, whoever saves a single life is considered to have saved the whole world. And again, when you ask people after they've made a living non-directed donation, they basically say they felt great about it. They felt really good about helping. How often can you walk into a hospital, walk out, and have changed the life of somebody, and not just that person's life, but an extended group of people, like that person's family, and they basically feel pretty good about it. Nevertheless, it's an unusual thing to do, and what kind of organizations, what kind of movements have been effective at getting people to do it? The two that I will talk about are effective altruism and renewal. Effective altruism is complicated. I'm going to spend a few slides on it, and I'm going to mention people's names and mention a few things. Again, there's a lot written about this, and it's very interesting. Preparing for this talk, I listened to a bunch of podcasts myself and watched a couple TED Talks, and again, very interesting stuff. The term was coined about 13 years ago by two people who are currently Oxford professors. McCaskill's the youngest professor in the history of Oxford, so effective altruism has been good for his career. But the goal here is to use evidence and reason to determine how to make the greatest impact. And so that sounds simple, it's complicated in practice, but it's how to use technology, how to use statistics to measure impact, to measure value. And it might be hedonic value, to promote pleasure, or to reduce pain. It might be other values, like how to keep the human race living longer, or to keep individuals living longer. There's a Center for Effective Altruism. One program they have is Giving What We Can, and it's basically does the math on how to make an impact with relatively small donations. Another thing is called 80,000 Hours, and it's how to make a difference through career choice. Again, these are interesting, and I'm not going to talk about them. What else might you want to know? One of their core values is that all lives are equally important. The classic EA idea is that if you see a child drowning in front of you, of course you would jump in, and almost everybody says they would save that person. But if somebody's dying of starvation across the world, by and large, people don't think about it too much. They would say those two children should be valued the same. Now, it gets into some complications. How do you measure some of this stuff? How do you measure racial justice? How do you measure the impact of capitalism? Is it really value neutral? How do you use math to decide whether you're going to distribute mosquito nets or whether you're going to tackle problems related to climate change? Long-termism is related to the idea that not only are all current lives equally important, but future lives are either equally important or at least have some importance. So one could do some things that many of us would consider unethical or immoral in order to benefit people in the future. That gets into dicey ethics. They also talk about space travel and the survival of the human race. In the world of philosophy, utilitarianism is considered a bit passé, and the EA people say they're not utilitarians. But again, if you want to listen to this, there's a lot on the internet about it, including people like who are Marxists who say if things are run by billionaires, one might want to be skeptical. But some of the most prominent, most best known people in this movement are the Gates. I guess the Bill and Melinda Gates are separated, but they gave $7 billion last year out of their foundation to do things that were considered cost effective that had an enormous impact. Elon Musk has said that his philosophy fits best with EA. I don't know how much he studied it, but I think he studied it. His idea for some of his spaceships is about survival of the human race. The Center for Effective Altruism has been able to corral quite a few of these very rich people, including a bunch of tech entrepreneurs, to donate money. They bought this castle a few years ago for conferences and things. And as one blogger said, he respects the fact that they did the cost benefit analysis, said this was a reasonable purchase, but that he respected the fact that they were willing to do good even if it made them look bad, because this looks bad if you're trying to squeeze every penny and save people in developing or poor countries. I think they're now selling the castle because it looks bad. Sam Bankman-Fried was a big proponent of effective altruism. He says here, I'm in on crypto because I want to make the biggest global impact for good. Again, they're complicated. And as you stretch the philosophy out, Peter Singer, again, he's another proponent of this. He talks about disability rights in a way that disability rights advocates get very upset about. Feel free to read about it. It's interesting. It doesn't directly relate to kidneys, because the kidney folks often have not stretched the ideas of effective altruism out to whether or not one should commit infanticide if it's for the good of the country, which is one of Peter Singer's points. The group that I've met are talking about how, hey, I've done the math, I can go in, it's a low risk thing for me, it's a high benefit to somebody else, I want to walk the walk. And, a lot of these people learned about effective altruism in college, they've studied philosophy, and as one person happens to be a psychiatrist, this is his nom de plume, Scott Alexander, who's got a very well-read blog. You want to just do one good thing that you'll feel unreservedly good about, and where somebody's going to be directly happy at the end of it in a way that doesn't depend on a giant rickety tower of assumptions. And he said afterwards, I feel good about it. Felt great, And so even though sometimes EA is seen as a non-feeling thing, it's about math, it's about statistics, it does lead to the benefit of people feeling better. They feel, as one person said, I'm not just saving somebody else, I'm saving myself. And that feels meaningful. I also want to talk about Renewal, which is a nonprofit donor-recipient matching organization, begun almost 20 years ago after somebody was talking to an acquaintance, heard that he needed a kidney. That person put out an ad saying, this person needs a kidney. They got 25 volunteers, and that person got a kidney. It has grown dramatically. It's organized largely within the Orthodox Jewish community. It's run within Renewal. So they look for donors. They have swab drives in synagogues. They do their own screening. They keep records of the people who've volunteered for months or years. So somebody may have get called in for a swab of somebody in their community in Baltimore or New York or wherever, and then they may not be the match, but they'll wait and they'll hear 3 months later or 3 years later that they're now a match, and would they be interested in donating? I'm a kidney transplant psychiatrist at Cornell, and I see all the non-directed living donors, so I see quite a few of these folks. And again, there's no sense, I've not gotten any sense that anybody's being coerced. And it's kind of one of the interesting things about doing the assessments, because when it's your sister or your dad or your child, there's a bit of an expectation that you're going to do it. And you often have some of the same risk factors as the person who you're trying to donate to. And you may or may not have ever been a very giving person in the past, or very altruistic person in the past. And suddenly you feel, or some other people feel, that you need to go do that. And so often when I see people who are relatives, I'm looking for coercion. I'm looking for a sense that they have to do this. I look for that in effective altruism patient prospective donors, and I look for that in renewal prospective donors, and it's just not usually there. I don't think I've ever seen it. They don't feel pushed. They do feel excited about it. Many of them now know people who've done it, and it's grown, again, as I said, significantly. They just celebrated their 1,000th living donor match, and there have only been 4,600 living donor, non-directed living donor transplants in the U.S. total. They've done a huge percentage. Currently, they're up to 60% of the non-directed living donors in New York State and 34% in New Jersey. Obviously, those are states with high concentrations of Orthodox and ultra-Orthodox Jews, and it's a tight-knit community with a strong mission to help people in their community. What do they have in common? And I was trying to think about that, and I'm not sure this is absolutely right. I see no evidence for it, but except that it sounds about right. But I think in both cases, these two different things, I'm calling them things. One is an organization, one is kind of a movement / community, but they encourage people to do something that they might want to do anyway, that they might want to help out somebody in their religious community, or they might want to make a gesture or make a real effort to help out the world. And the movement part of it brings them in and encourages them to go forward. And it reminded me of a line from Pride and Prejudice. There are a few of us who are secure enough to be within love without proper encouragement. People need a little encouragement, and they provide it without, in my experience, being at all coercive. They also have in common that most of their members tend to be relatively healthy, physically healthy, and be socially connected. They are not probably going to get ruled out in our screening process. They tend not to, again, in my experience, they tend not to be substance users. They tend not to have diabetes, hypertension, metabolic syndrome issues. They get through. They get support. And then there are questions about how to, because you want to, in some ways, encourage this kind of group effort in other groups, including groups whose target audience or whose mission involves people who are disenfranchised in this country. Both of them were kind of homegrown. Nobody was sort of pushing that from the outside. But a lot of the groups that might do this from within the disenfranchised communities, they could use some external support, sources of support, some financing, some coordination. But it's also really important that the donors communicate their happiness with the process. The people who I've talked to, they really appreciated the opportunity to donate. And in both cases, they make it public fairly often. From within the effective altruism movement, a bunch of people have written articles about their experience. They include a New Yorker article from 15 years ago, The Kindest Cut, What Sort of Person Gives a Kidney to a Stranger? And then first-person things like why I gave my kidney to a stranger, why you should consider doing it too. In Vox, again, which gets to a fairly narrow sliver of the population, but the kind of population that would be interested in effective altruism. A similar title in Medium, another one in Defector came out 6 months ago, or actually a year ago now. You too can donate a kidney and still be a normal, cool guy who pounds brewskis. That made all of us cringe a little bit, but in reading it, he's reaching his audience. Similarly, Scott Alexander, the psychiatrist I mentioned, he wrote about My Left Kidney. He's got a blog. He's got an ongoing effective altruism blog and Substack, again, that reaches a target audience. And in that way, they provide support. And there are these podcasts. If you'd like to know more about effective altruism, here they are. Feel free to look them up. You can just pause and write them up. There are a lot of others. I've listened to almost all of these. I listened to all of them a little bit. I didn't finish two of them, but they're good. They're interesting. Writings about renewal are different. They are not spread out into the internet, but they are targeted. The writings on EA are targeted to kind of a techie, young, very savvy crowd about effective altruism and also about the internet. The writings about renewal are largely within Jewish newspapers, Jewish websites. There are occasional articles in on TV and things, but they're talking about Lubavitcher was needle in a haystack match for kidney donation, and then she got the kidney. My donor wanted to give me your kidney and get home in time for Shabbat. They know their audience. They're reaching out. And there are many of these articles, and they're often in local newspapers throughout the country, and they bring people in. I've met people from all over the East Coast. I'm not sure if I've seen West Coast. They might go elsewhere for the West Coast, but the East Coast folks come in, and I often see them. How do we expand this pool of living kidney donors? There's a proposal, not surprisingly, it's got a lot of traction within the effective altruism population, to give it tax credit, not just hand over a bunch of cash, but if you give 100,000 tax credit spread out over 10 years, it's a huge amount of money, but it's spread out. It's not like you're going to get somebody desperate for cash to go get it. But that's ethically controversial. I don't see any real movement towards that right now. But how do you get people to identify potential donors who want to just give, swab them, screen them, identify them, catalog them, keep them on hold, and then when you've got a match, encourage them, grab their passion, provide support? Hard to do. Obviously, the national organization, National Kidney Registry, these different groups do a terrific job, but how do they get into the populations that are at special risk? And it's tough. The organizations like churches, say, that work within the populations that are historically disenfranchised, they have a lot to do. They already have a lot of competing needs. They don't have a lot of resources necessarily. How to enlist, support them, provide them whatever infrastructure we can provide. Maybe those effective altruists can toss some money in that direction. I don't know. There are a lot of possibilities, but it is a interesting thing about what works and how we can enlist them for the future. Thanks a lot.